Good morning, all. Very welcome to this online webinar about the PRESCRIP-TEC project and the lessons learned from that. My name is Helene van Beekhuizen. I'm a gynecological oncologist from Rotterdam, and I'm special interested in elimination of cervical cancer. This webinar is about whether the elimination of cervical cancer is feasible globally. That's a very exciting topic, and I'm very much looking forward to the discussion. I would like to ask all the audience to put questions in the Q&A below your screen and not in the chat. As you know, cervical cancer is a major global problem, mainly in low-resource settings. Cervical cancer claims death of around 3,000 women yearly, and 90% of them occur in low and middle income countries. In August 2020, the WHO started the elimination strategy for cervical cancer. In this strategy, the 1970-90 figures are very clear, and 90 means 90% of the girls vaccinated, 70% of the women screened, and 90% of the women with pre-invasive or invasive cancer treated. To eliminate cervical cancer, each country should meet these targets in 2030. The PRESCRIP-TEC project runs from February 2021 to January 2024 in 4 countries: Bangladesh, India, Uganda, and Slovakia. Screening for cervical cancer was researched. Especially the HPV testing had a central role. In this conference, we will discuss the hot topics about this PRESCRIP topic meeting. And I'd like to introduce my co-chair, Dr. Ishu Kateria, a public health researcher and a Lancet commissioner. Ishu, go ahead, please.
Thank you, Helen. Greetings, everyone. I'm Dr. Ishu Kataria. I am a public health researcher by training, and I work with the Center for Global Non-Communicable Diseases at RTI International. I basically work on NCD prevention and control, both in India as well as globally, and have a particular interest in cancer. I am very fortunate to co-chair this webinar with Helen, and I'm looking forward to the interesting discussions we will have to follow. Back to you, Helen. Thank you.
Thank you very much, Ishu. I would like to introduce Dr. Jaap Koot. He's the main person from PRESCRIP-TEC, and he will introduce himself and present the video. Jaap, go ahead, please.
Thank you. Well, I'm not the main person. I'm maybe the coordinator, but the main persons are the ones that have been working in the field, doing all the work. And I would like to thank, first of all, our co-chairs, Dr. Helen and Dr. Ishu, for guiding us through this online conference, and also all the panelists who you will hear later for their readiness to contribute to the discussion. And of course, the participants in this conference for joining us and hopefully contributing to the discussion through the Q&A possibilities. Well, this consortium called PRESCRIP-TEC Prevention and Screening Innovation Project towards the elimination of cervical cancer is financed by the European Union and co-financed by the Department of Biotechnology in the Ministry of Science and Technology in India. So we got international support for carrying out this research. And as Dr. Helen said, we have been working in 4 countries, Bangladesh, India, Uganda, and Slovakia. And we have been working in this consortium with 12 universities, 7 NGOs with practice in cervical cancer programs, and 1 small company, the communication company, Connexis. So we have been working for 3 years in this project and come now to the end of data collection. We still will be working for more time on the data analysis and production of scientific reports. And in India, the project will still continue for 1 more year. Instead of me talking about the project, I think we have a very nice video explaining our work with the different people from the different organizations explaining what they have been doing. So Oscar, I would like to ask you to start the video so that people can see what we have been doing in the past 4 years. Thank you. Oscar, there is no sound in the video.
There is no sound. Okay.
Oscar, there's still no sound. Can we request Katrina to play it again with sound? To everyone in the audience, we are trying to fix the sound, so please bear with us. We should be able to get it back very soon.
I think we should start with the presentations, and then we will show the video later when the sound is prepared. So maybe I can ask the co-chairs to continue with the sessions. Thank you.
I would like to invite Marieke de Vaux and Jochem Beltman to start a presentation about community mobilization and self-tests. Please go ahead.
Can you see my screen?
Yes.
Sorry,
No.
I think I just closed. So while I'm opening up the presentation, thank you all for joining us in this webinar this morning. And I want to start with the presentation to address the community mobilization activities that we did. So I'm Marieke de Vaux. I'm a registrar at LUMC in the Netherlands and work as a supervisor and technical advisor for the Female Cancer Foundation. At the beginning of this PRESCRIP-TEC project, we wanted to understand better the knowledge and the screening behavior of the populations where we conducted our project. And we also wanted to get more insight in the decision-making practices of the population. In order to do that, we conducted a household survey at baseline prior to our community sensitization activities and prior to starting the HPV screening. In order to do that, we included women eligible for screening in all our catchment areas and also addressed their household decision makers, which depending on the context could be either their husbands, mothers-in-law, or other family members that supported them in their decision-making processes. We addressed them with questionnaires, including the ABACAN questionnaire, which is an African Women Awareness of Cancer questionnaire that is developed to design the awareness of cervical and breast cancer. And we adapted it to the cervical cancer part and translated and pilot tested it in every context. I want to share with you the main findings of the household survey. Some of the socio-demographics that were important. As you can see, in every country, we addressed around 500 to 700 participants. The age was quite young, around 36 years median. The educational level on average was low, with no education or primary education for the majority of the participants. Most of them were married and most of them lived in rural areas. Then if we look at the knowledge and participation of the participants, we saw that most women had heard of cervical cancer. As you can see, that ranged from 70% in the Slovak Republic and Uganda to about 80% in Bangladesh. But if you look at the participation of women in cervical cancer screening, that was really low, ranging from 5 to 9% in Bangladesh, Uganda, and India, and up to 26% in the Slovak Republic. It was an interesting finding because often in literature it is mentioned that knowledge is related to participation in screening. And we also saw that in our findings, but at the same time you see even if women know about cervical cancer, the participation in screening can still be low. So there are other factors in play that are important for women to participate in screening. As previously said, we also wanted to understand the decision making. So we included husbands and we included mothers-in-law. And actually the knowledge was better than we expected. As you can see, the range was again from around 60% to 70% of the male decision makers that had heard of cervical cancer. And for the female decision makers, that was not applicable in Slovak Republic and Uganda, but it was there in Bangladesh and in India. They had similar knowledge compared to the women themselves in the target group. So there was also an interesting finding. They're important in decision making, which I will show in the next slide, but their knowledge on cervical cancer was actually quite similar to the women in the target group. As you can see, there's a difference between India, Bangladesh, and Uganda, which we need to study a bit further why the knowledge in India is lower than expected. Then the decision making. In this figure, you can see the different countries, and the color indicates who took the decision regarding participation in screening. White represents a joint decision with the woman and the decision maker together. Pink, the woman herself, and the more green color is the partner. And as you can see in Slovak Republic, it's mainly the women themselves that take the decision to participate. And in the other countries, actually, it's either a joint decision, and also the partner takes a very important role in decision making. So we decided based on these findings that it is very important to include also the decision makers in the community sensitization activities. And in the video that will be shown, you will see a little bit more examples of the community sensitization activities that we did. Now I want to give the floor to Dr. Jochem Beltman, who will continue about HPV testing.
Thank you very much, Marlika. I'm Jochem Beltman. I'm a gynae oncologist working in Leiden University Medical Centrum, and I'm also a board member of the Female Cancer Foundation. I will continue the presentation about the screening strategy of the PRESCRIP-TEC, and only women who were tested HPV positive were invited for VIA, and once they were tested, once they received a VIA, we also used a decision support system to improve quality of diagnosis. And if VIA positive, women were offered either direct treatment if eligible, and if not, or suspicion of cancer, they were referred. Next slide, please. So if we look at the different materials used in the participating countries, we see that the flock swab was used in all countries. There were two different PCR real-time platforms, the Gene Expert and the Roche Cobas, and we had the mSwab medium used in Uganda and Bangladesh, and in India there was the PRESCRIP-TEC medium, and the Roche medium was used in Slovakia. Next slide, please. Yes, and then we come to the HPV testing and our main conclusions. So there was a very high acceptability of almost 90% of the cell swabs. Over 27,000 women were tested in all countries. And if you look at the HPV test results, we see a wide range of HPV prevalence. 2% in Bangladesh, 6% in India, and that's also depending on very much on the site, on the risk groups being tested. You see among women living with HIV and sex workers, the prevalence is of course higher. 6% in Slovakia and 22% in Uganda. If you look at the invalid results, it's almost 2%. And if you look at the error rate, it's 2 to 3% for the Gene Expert and 6% for the Roche Cobas. Next slide, please. If you look at VIA and treatment, we see that the VIA uptake of HPV positive women is a little bit later than the uptake of HPV testing. In Uganda, it's 65%, of which 15% was VIA positive. In Bangladesh, it's 83% uptake, of which 40% is VIA positive. And in India, it's 67%, of which 20% is VIA positive. It's important to mention that this testing is still ongoing. So fear of treatment, but also influence of family on decision-making of women could have been the cause for this lower uptake of VIA. If you look at the treatment uptake after VIA, we see that Uganda has got 99% of the VIA screened women conform protocol where all HPV positive women are being treated. In Bangladesh, it's 93%. In India, it's 84%. And of the HPV women referred for cancer in Uganda is 0.4%, Bangladesh 2.4%. In India, there hasn't been women identified yet with cervical cancer and referred. So the next slide, and what are the lessons learned? We all know the WHO targets. Dr. Helene was mentioning them. If we focus on the latter two, the 70% of the screened women, of the women who should be screened, and 90% of the women identified with cervical cancer disease should receive treatment, and we compare this with the PRESCRIP-TEC achievements, we see that the HPV self-test can reach 90% uptake. The uptake of the VIA is a little bit less, but we see the ablative treatment, the uptake is over 90%. 2% of the HPV positive women were referred for a suspected cancer. Next slide. So I think here ends our presentation. For reference, but also for the discussion later, it will be useful to use this table with the overall results. And next slide. I would like now to close the presentation, and on behalf of Marlika and myself, I would like to thank you very much for your attention. And I would like to give the floor to our esteemed colleague, Dr. Kirtana Prasad.
Good morning, good afternoon. Am I audible?
Yes.
Greetings from India. This is Kirtana Prasad from Manipal School of Information Sciences, India. I'll be talking about AI-based decision support system for VIA evaluation in cervical cancer screening. Visual inspection with acetic acid is the commonly used approach for cervical cancer screening in low resource settings. And Saki Manipal is an AI-based decision support system for VIA evaluation. This was developed by the team in Manipal in India here. And this was with the main purpose of task shifting where there are no gynecological experts to do the VIA evaluation. And through PRESCRIP-TEC project, we validated the use of Saki Manipal. Just to give a very quick demo of the kind of features that we have in the Saki Manipal device. It is Saki is an acronym for Smart AI Kit for Healthcare Innovation. We have intentionally focused on using symbolic user interface, and we have two modes of operation as of now, and one is an expert mode and the other one is novice mode, with a slight difference which I'll come to you later. But then we have all these icons, pictorial representation, so that the health workers will not have any language barrier, and any country we will be able to use the this application easily. So we were focused on making it with an end user comfort, and that is what we had focused when we developed this. And as we start this, Saki Manipal is a mobile phone which is converted into an AI device where all the wireless communication channels were all disabled. And as we start the device, this is the dashboard that we get. And there are two modes that you can see. One is the expert mode and the other one is a novice mode, and this is represented pictorially there. And when I will show the expert mode now. So when we start with, when we click on the expert, then we get this window where we have on one side, we have all these icons that I showed you earlier in the previous slide. So we can use the camera picture to capture the patient ID. Now the patient ID is captured as a picture so that there is no error that the health worker makes as the patient ID is entered into the system. And once this is done, the patient's cervix is cleaned and the cervix picture before the application of acetic acid is captured. So, and before that, sorry, so before that, we check whether the image that we captured is okay or not. So there is a confirmation window that is available, and we could click on this okay, so that this particular picture that we have captured is accepted. And if the picture quality is not good, we can reject it and retake the picture. So once the cervix picture is captured before the application of acetic acid, this is how you see on the screen. And then you can move forward to the next step, where we apply the acetic acid on the cervix, and after 1 minute we capture the picture again. So that is what you will see here. So we have this is the picture of the cervix after application of acetic acid. Then in one of the modes where we facilitate the health worker to give the decision of this particular cervix, whether it is normal, abnormal. So that is what you can do here. That green is negative and red is positive. So the health worker can give the decision entered into the system. Once it is entered and locked, then we can even have the AI verdict coming out. So the AI can, you can press again to get the AI verdict, and we get the AI verdict as positive here. So this AI verdict and the verdict of the health worker and these pictures are all saved in a particular folder within the device that can be accessed later for a second opinion. And the other mode is where this health verdict by the health worker is not provided. That facility is not provided. And now this device can also be used for quality control, where the health worker's decision making is compared with AI decision making or an expert's decision making. So that was about how the Sakhi Manipal device screen looks. And why Sakhi Manipal? What is the other option that we have? We have other option where AI can be used for cervical cancer screening for VA assessment. These are the two commonly used ones, which is EVA Pro by Mobile ODT, and Periwinkle Technologies have come out with Smart Scope. And compared to these, if you look at Sakhi Manipal, the screen, the usability of this particular device, it's intuitive, where there is symbolic picture, so it's simple. And more importantly, the health workers are all used to using a mobile phone for capturing pictures. So that is the one which makes the learning curve, which is very small. Also, another important aspect, the difference is that this is a standalone device and it does not require a cloud connection or an internet connectivity for giving the decision. So the intelligence is built into the device itself, and the device gives an instant result then and there. Also, it is highly portable and inexpensive and secure, where the data privacy is maintained and encrypted and password protected here. So just to give you a background about the development of this particular device, it was based on, technically speaking, it is developed using a deep learning approach. And there are two steps. One, we capture the picture, and the cervix from the picture is extracted. That is what we call region of interest detection. And once the cervix is captured from the image, then we go for classification. So classification gives you the positive and the negative decision. And when we developed this particular AI algorithm, the accuracy was around 92%, with the sensitivity specificity as 98 and 88 around. So this algorithm that we developed then was embedded into the Android device as a mobile application. And using this application, we can acquire the pictures, and these are stored into the device, and it also provides an instant decision. And this images that are stored here can be used for second opinion too. And the data protection and privacy is taken care, and all the communication channels are disabled, and the images, the data that is stored into the device would be passed through wired communication to a computer for further processing. Through this, with this Sakhi Manipal device, as we started off with the project, we initially started with the dry run analysis. So through a dry run, we had 22 health workers who participated for this dry run, and we had 9 gynecologic experts, and we had 83 images from existing data sets. And then we see the performance of the healthcare workers, the experts, and the AI, and the comparison is shown over here. And you can see that the performance is comparable. The healthcare workers' performance could be slightly less, but AI is around the same. So we could then see that, okay, expert consensus was obtained as the ground truth or a reference standard, and then the AI could be used for task shifting, or we would want to use the Sakhi Manipal for further usage through this particular project. And AI could improve the diagnostic accuracy to support the health worker in the decision making. So through this project, as we use the AI for the VIA analysis, we had to use 2 panels. This is because of the data sharing issues, because for India, the images were collected, were analyzed within India, because the data sharing protocols were not allowing us to share this. But otherwise, so we have 2 panels, and there were 6 experts. And when the experts meet, experts would meet when there is no consensus of the evaluation. So online panel meetings were organized. And overall, 511 cases were analyzed, 305 from Bangladesh and Uganda, whereas 206 from India. The accuracy, the performance of the AI is shown here on the screen. Around accuracy was around 66%, and the negative predictive value was okay, around 89%. However, the sensitivity specificity was a little low. And out of these, why is it low? Because out of these 511 images, 53 had to be rejected because of the quality of the image acquisition. So this is because initially there was a lot of variability among the images that were collected, and the cervix was not properly visible. The SCJ was not visible. So there were challenges with the image acquisition, and because of that, we had to eliminate some images. Even otherwise, I think that brings in the learning that health workers need to be really trained. Even after the familiarity with the device, their health workers need to be really carefully capturing the pictures. The prevalence was found to be around 15.4. So we also then looked at the initial, when we developed the algorithm, that was the lab condition, we got very good sensitivity specificity. And coming to the dry run, the sensitivity specificity was slightly low. And in the field condition, it is observed to be low. Now, the reason could be that, one, the image quality, mainly the quality of images, and secondly, the kind of images that are being captured from the device currently is very high resolution images in comparison with the images that were used for developing the AIDSS. So, however, we observe that the accuracy of the Sakhi Manipal AI decision support system is in line with most of the studies applied in the LMICs, and the fact that there is a high negative predictive value indicates that there could be lower false negative cases, and that is what we need in the case of screening. So we understand, or we decide that there is an update of the algorithm that could definitely influence the performance of the AI in the future, and this will be done with the images acquired from the current device that we are using for this project. And if we can prove that, and we hope, I mean, it's possible, and with that, the task shifting can be enabled. And so to conclude, the performance decrease that we observed was attributed to the quality of images, and it is calling for good training of the health worker to acquire the images. And the performance of AI could be improved using the image, training the AIDSS module using the images acquired from this device, and it should be retrained, and that's what is being done now. And a real-time feedback to user on the improper quality of image, if that can be automated, then the health worker can be made to capture the image which is right enough for making the decision. So that is another important point that we observe as a possibility for the future work. So overall conclusion could be that the AI is a promising technology solution to facilitate task shifting in LMICs for cervical cancer screening. Thank you.
Next person.
So over to Yurian on cost effectiveness.
Thanks, Dr. Kirtana, for the very interesting talk on your work in India and beyond. Let me share my screen. Okay, you should be able to see my screen now. Let me go to full presentation mode. I think my full screen should be. Second. Is my full screen visible now? I think so. Okay, if not, then
It is visible, but sorry, it is visible, but it's showing the presenter's mode.
Oh, yes. In the test run, it should be full mode. 1 second. Okay. What do you see now? I think you should be able to see my screen now.
Yeah, please put it in presentation mode. Yeah.
Yes.
Is it now visible for everyone?
We see the screen.
It is visible, but not in presentation mode. So we see the small slides on the side. But anyway, go ahead. It is to do, I think.
Well, I'll try to fix it in between, but I'll at least start my presentation. So my name is Jurgen van Schans. I'm an health economist at the University Medical Center Groningen. And I'll be talking about the value and affordability of cervical scanning, cervical cancer screening within the PRESCRIP-TEC program. So 1 second. Yes. So sorry for this inconvenience, but yes. I think now it should work.
Perfect. Go ahead. Oh.
Yeah. Now it's the full screen, I think.
Yes, it is.
Okay, perfect. Let me see. Yes. Oh, no. Sorry, guys. It worked perfectly fine in the. I'll just go ahead without it, but 1 second. So I'll be talking about affordability and value of the PRESCRIP-TEC program. So I'm a health economist, so I look at the consequences of cervical cancer screening on the long term, not only considering the health effects, but also considering the broader economic effects. So I think you see my screen now. I'm not going to zoom in and do it in presentation mode, but I think it should be visible. So just look at the health economic concepts, a little bit of health economic evaluations. So we have kind of the goal to balance care demand and care provision, to support decisions on investments of specific interventions, look at designing of interventions, research of interventions, but also pricing and market access. And we do this by means of an objective evaluation of, in this case, prevention, but also sometimes diagnostics of therapy, by looking at the safety and efficacy of specific interventions, and also at the impact on clinical outcomes, clinical effectiveness, but also on cost or cost savings. So in general, HPV testing is seen as cost-effective compared to specifically no screening, but also to a VIA-based or cytology-based screening strategy. This is the case because it reduces cervical cancer cases and cervical cancer related mortality, although there is, of course, some investment needed. However, there are some critical factors which you should take into account. First factor, specifically epidemiological factors, such as HPV or cervical cancer prevalence in a specific country. So the higher the prevalence or cervical cancer, that changes the interaction between the cost effectiveness of introduction of a new strategy, duration of under screening HPV or cervical cancer. Also, the quality of the screening program, so whether or not you lose along the screening flow, you lose people, so the loss to follow-up rate. Also what the effect is of the increase of the population in terms of coverage and uptake, the accuracy of the screening sequence, so not only of the first step, test, but also of the sequence and the triage steps, and also, of course, the age of delivering the specific screening of the population itself. And there is an interaction with the cost of the screening program. Of course, the programmatic cost to sustain screening, uptake, and follow-up needs to be considered, how they relate to the factors above. And specifically, the combination between factors is essential. So does high cost of a program, for example, an introduction of HPV screening program with a full campaign to increase uptake, does it justify the effect shown? So what we did a model-based economic evaluation, which takes into account multiple sources of evidence, among being the PRESCRIP-TEC program. We looked at specific disease characteristics by means of a cohort of non-vaccinated women from birth to death in the specific countries, so India, Slovakia, Bangladesh, and Uganda. In that specific cohort, there were natural transitions between being healthy, HPV positive, SIN lesions, and cancer states. And we validated this natural progression by means of HPV and age-specific cervical cancer prevalence of each country. So the screening characteristics in this model-based evaluation were based on the screening flow, as also talked about before, and also the business as usual. So what happened before the introduction of the new PRESCRIP-TEC program. And we looked at the impact on individuals, society, long-term cost and effect. So not only the investment we needed to do in the screening program, but also what does it save on the long term? So for example, prevented cervical cancer cases and the related treatment. And we also looked at the effects expressed in life years gained and disability adjusted life years. So country-specific input. So what I first described is just a general kind of outline of the evaluation. Now we look at what did we put into this model. So first of all, the coverage, uptake, and compliance is also discussed by Dr. Jochem and Dr. Malike of the PRESCRIP-TEC program. We looked at the HPV prevalence, the distribution of cervical cancer survival, but also divided this by age in the specific countries. And we have, of course, included cost of the interventions and the benefits of screening. So, for example, screening campaigns, our community awareness and mobilization campaigns, but also introducing more expensive HPV tests, fewer women who need VIA or pap smears in the countries because of these HPV tests. Fewer women who need frequent screening, but also early detection and treatment before complication arises. It can increase cost on the short term, but it will probably save a lot of cost on the long term, or at least life years. So this is, and sorry for, I'm not in presentation mode, so there's no visuals, but this is the kind of the situation before the introduction of the PRESCRIP-TEC program. On the left-hand side, you see the incremental cost effectiveness ratio. So these are cost divided by life years, kind of a proxy for cost effectiveness or value of a specific intervention. And on the x-axis, you see the HR-HPV prevalence. So here we explored, this is a study we did before the PRESCRIP-TEC program was completed. Here we show kind of the interaction between value of the intervention versus HPV prevalence in the specific countries. And you see here Bangladesh, Slovakia, India, and Uganda all having different HPV prevalence rates, which are now shown also in the results of PRESCRIP-TEC. So what we see here in the orange line is the PRESCRIP-TEC program, and what we see here in the blue line is kind of the business as usual situation. So usually the VIA-based or cytology-based screening program, which was already present in the countries itself. And we see by comparing these that the HPV program, so the PRESCRIP-TEC program, is actually quite expensive. It is cost effective, so it is efficient in what it does, especially compared to no screening. But if you compare it to a business as usual, so the situation in the countries themselves, and assuming that they have kind of similar uptake levels, then the HPV screening test is too expensive. And also what it says here below, a price reduction is needed of about 70 to 85%, depending on what the HPV prevalence is, of the HPV testing procedures in order to be affordable in Uganda, India, Slovakia, and Bangladesh. So this is a situation before the introduction of the campaigning and the PRESCRIP-TEC program, but already shows either the potential of the HPV program, but also the fact that it's maybe still a bit too expensive. And the 70% is mainly in a situation like Uganda, so where there's high HPV prevalence, the 85% is more likely to be around the Bangladesh situation. So now what if we introduce the community awareness and mobilization campaign, is also shown in the first presentation of today. We looked at mass communication, group communication, and interpersonal communication. And we counted labor cost, transport cost, material cost, venue cost, but also involvement of extra non-paid workers, which is a very important aspect, usually forgotten in these kind of analysis, and can really strengthen the communication activities, but are usually also very expensive because you're asking people to spend some time on these activities. And also the support and consultation by our communication partner, Conaxis. So just to give an overview of what the investment costs were, so the cost going into the intervention, the total cost in Bangladesh, Uganda, and Slovakia differed between 200,000 euros and 100,000 euros in kind of the case of Uganda. Eligible population in the target area, so eligible women in the screening age were between 8,000 and 20,000 women. So we paid around, including all the costs, also the non-paid cost, between $5 and $23 per woman to get them motivated and to get them out there to the screening activities itself. So now looking at a specific case of Bangladesh, just to highlight, I think, the impact on affordability and cost effectiveness. So we took the uptake and HPV screening and VIA screening of 94.5%, about a 80% increase compared to the business as usual, which is quite good. This kind of had as a consequence that the cervical cancer incidence rate per 100,000 women dropped from 21 per 100,000 to about 18 per 100,000, which is quite a good increase, or kind of a decrease. This saves on the long term, so not right now, but on the long term, it's projected that it saves about 0.07 life years per woman of the whole population. So this is actually, it seems quite low, but comparing this to, for example, a Dutch screening program, it is actually quite an impactful screening program in that sense. So the incremental cost, so the amount we had to invest extra on top of the business as usual strategy, was about $20 per woman. And this led to about a cost effectiveness ratio of $276 per DALYs, which is a adjusted life years in terms of quality. And that's about 11% of GDP per capita. Well, if we look at the kind of unofficial guidelines of the WHO, they say, well, somewhere between 1 and 3 times GDP is already cost effective. We see in real life that it's usually a 10% GDP per capita seems as very cost effective and reasonable to introduce. So we say that there's about a cost reduction needed of 15% of the PRESCRIP-TEC screening program in order to outperform current strategies in Bangladesh. But in order for it to be affordable, so we're looking at kind of a threshold of $100 international dollars, we need a 65% reduction in cost of the whole screening program. So concluding this, HR-HPV screening and PRESCRIP-TEC screening program itself are cost effective. However, the HPV screening is only affordable if the cost of the HPV screening procedures, so not only the test kit itself, but the whole procedure, is reduced by 70 to 85%, depending also on prevalence rates. And the PRESCRIP-TEC screening program is affordable if the cost of screening and information campaign is reduced by about 15 to 65%. So cost effective, but for in order to be affordable, we have to look at how this can be reduced. Just a side note, I think it's also important to mention that this is the situation like we've seen it in the PRESCRIP-TEC program. And I think I'm quite hopeful that, especially because of economies of scale, this can be enhanced by introducing this in a larger population within the Bangladesh, India, Slovakia, and Uganda populations. So we're currently also running those analyses to see what is needed in kind of an upscaling situation in these hard-to-reach areas. And I'm quite hopeful that it's specifically the PRESCRIP-TEC program can be affordable also for those populations, at least if there's a price reduction of the HPV testing. So sorry for the inconvenience for my presentation. I want to thank the PRESCRIP-TEC country teams, of course, which assisted and helped a lot with getting this data ready, and also, of course, our health economy team here in Groningen as well, of PhD students and master students. Thanks a lot. I think I give the floor back to you, Katarina.
Thank you very much. Thank you for your presentation. So while we've heard about the PRESCRIP-TEC program, the next presentation we are going to hear from Dr. Morven Roberts on how the PRESCRIP-TEC fits within the bigger picture of the GACD cancer research. Dr. Roberts is the Chief Executive Officer at the Global Alliance for Chronic Diseases. Over to you, Morven. You're muted.
Hello, everyone. I'm Morven Roberts, the Chief Executive of the Global Alliance for Chronic Diseases. And I would like to firstly thank the organizers for inviting me to participate at the first meeting to disseminate some of the preliminary results of the PRESCRIP-TEC project. Helen and Jaap and others have already provided a really excellent introduction to cervical cancer and the challenges that we all face in tackling this issue. But I'd like to set this into the intention of the overall activities of the Global Alliance for Chronic Diseases. So with my next slide, the Global Alliance for Chronic Diseases, or GACD for short, was launched in 2009 as an alliance of international health research funding agencies who were particularly concerned by the increasing global burden of chronic non-communicable diseases, particularly in low and middle income countries and in populations facing conditions of vulnerability in high income countries. Indeed, the flags on my slide here represent the countries in which these funding agencies are based. And of course, you will see the European Commission flag as one of the funding agencies engaged under the Global Alliance for Chronic Diseases. Together, the funders work towards informing practice and policy on how best to tackle NCDs through the three strategic approaches, which are to invest in relevant high-quality implementation research, to build research capacity in implementation research, and to foster collaboration and partnerships to drive forward the likelihood that these activities will have impact. Now, cancer as an NCD is one of the most important public health problems worldwide. It's a leading cause of death, accounting for nearly 10 million deaths in 2020, which I think is when the last major consensus was taken. The problem is particularly increasing in low and middle income countries, which are seeing expanding but aging populations, sees high level of risk, and also have socioeconomic inequalities that result in untimely care seeking, poor cancer provision, and poor quality of care. Cervical cancer, I've highlighted that in the WHO teal color, is the fourth most common cancer in women globally. And we heard from Helen that it brings around an estimated 604,000 new cases and approximately 3,500 deaths in 2020. Importantly, it's estimated that 30 to 50% of all cancers are preventable. And specifically, 1/3 of global cancer deaths can be related to risk factors such as tobacco and alcohol use, low fruit and vegetable intake, obesity, and lack of physical activity. However, around 25% of cancer incidence in LMICs is attributable to vaccine preventable infections. And cervical cancer is caused by persistent infection with the human papillomavirus HPV. I'm sure you are all well aware of that, but it's a point that I thought it was important to make again. Indeed, therefore, it should be no surprise that given the importance and the potential for intervention, it's no surprise that the funding agencies amongst the Global Alliance for Chronic Disease agreed to support a call for implementation research around cancer prevention as its 6th call. It's the one highlighted in pink here on my slide. And that call was launched in 2019-2020. Now, I've also mentioned that the focus for GACD and the funding agencies therein is implementation research. And that's quite important because we're not really looking for research that looks at new tests or new methods of treatment. It's not looking at the development of new interventions themselves. Implementation research really focuses on the no-do gap. And that is what is how to best take an intervention that we already know can work in one set of national circumstances and explore through systematic research the strategies around how to make those interventions work in very different contexts, cultures, environments, such that the evidence-based intervention can be adapted whilst remaining effective, and it can be scaled up in ways that are accessible and equitable. So that's importantly the focus of GACD research. So within our call, we were able to collectively support a total of 23 different projects in 40 countries around the world with an investment of more than $30 million US. All of these projects become part of the GACD Cancer Research Program, where projects are invited to network and share knowledge across the program to maximize the collective potential of the impact of their findings. And the teams within the projects become part of our larger GACD research network. Now, at the time that we were launching, serendipitously, the WHO had increased its drive towards cervical cancer elimination, setting out targets around the evidence-based interventions that can work to prevent cervical cancer. So they gave a good reminder of what the known interventions are, including vaccination for girls with HPV vaccine, screening of women with high-quality tests, and the early treatment of women with cervical disease. Cervical cancer can be cured if diagnosed at an early stage and treated promptly, and these interventions are included now amongst those considered the WHO best buys. And this momentum was very much reflected in the projects overall that GACD have supported. Now, I said that we in total supported 23 projects in our cancer call, but 15 of these projects are either fully or in part focused on prevention aspects of cervical cancer. This image here, our map, specifically sets out those countries in which those projects are taking, and you'll see that we have a worldwide spread of projects. I've listed the 15 projects. On one side, you probably cannot read the small writing, but I'd invite you to go to our website to find more details of each of those projects. In many, there is cervical cancer being tackled as part of a more general integrated approach to broader cancer detection, using particularly, not using, but for example, within indigenous traditional health systems or in other vulnerable groups in high-income settings, often not well served by the sort of regular healthcare system, such as people who are homeless. However, by far and away, the major thrust of most of the projects is to improve awareness and understanding of HPV and its association with cervical cancer amongst women, and to explore strategies of how to offer effective but acceptable and equitable screening in women linked through to prompt treatment. So there's plenty of food for thought, for discussion across all the projects, when so many are actually focusing in a particular area, but doing so in very different cultures and contexts. I think we have only one project itself that explicitly is including the intervention where it's the vaccination intervention itself. And as I said, you can find more detail on all of our projects on our website. With my final slide, I'd really want to mention that for us, we've determined that implementation research is a particularly collective and collaborative endeavor, drawing on multiple disciplines in order to address the complex implementation challenges of real-world situations. It's often undertaken by multinational teams, and I think PRESCRIP-TEC demonstrates this absolutely so well, being a very large international consortium, but whose combined expertise and situational knowledge is required to deliver robust outcomes. And it's doing so in an equitable way. It is also that in applied research, such as implementation research, it's really important to have the earliest engagement of the stakeholders who will ensure that their outcomes of the research being undertaken will be sustained and will have likelihood of impact. And that particularly includes the community anticipated to benefit from the activities. Now, one might think cervical cancer, it's clearly going to benefit the women, but actually surely it's the women, their families, their communities in general who will benefit. It's really also very interesting to hear that in certain contexts, in certain environments and cultures, it's really important to engage the entire community in awareness of HPV and its impact to cervical cancer. So drawing in the husbands, the mother-in-laws, the elders in the community, clearly key. Really interesting to have learned that from PRESCRIP-TEC. But it's also clearly important to bring in the implementors and those who are the practitioners who will provide aspects of the health service. And we heard about potential needs for training healthcare workers in PRESCRIP-TEC on how best to use some of the tools available in terms of the new AI and picture taking. It's also vital that the local and national policymakers or policy influencers have been engaged because they potentially have the capacity to change practice and policy. It's great to hear about the accelerated use of innovations such as the AI being used in PRESCRIP-TEC. Clearly, new digital technologies were brought out, particularly in difficult circumstances such as the recent COVID pandemic. That has enabled a bit of a springboard to future use of such technologies. But we always must make sure that however we use such technology, we are doing so in an ethical way that is relevant to the particular population, that is, that they are fed by the relevant algorithms, and that actually the use of such technology doesn't actually drive deeper disengagement or inequity in access to care. Finally, I'd just like to say that research, of course, does take time to deliver. PRESCRIP-TEC is one of the first projects to come to an end. It's not quite ended yet, but we do hope that in due course, we will be able to combine the important outcomes from all of our projects and that they provide information useful to those working towards the improved management of this condition. I think I'll stop there. I'm really happy to take any questions or any comments. Thank you for your attention.
Thank you, Dr. Roberts. This was very useful to hear not only about the PRESCRIP-TEC, but how the project fits in the bigger scheme of things through the GSCD as well. So what I'd like to do now is to share some reflections on what are some of the key messages that have emerged from what we've heard so far. So I begin with self-sampling, and what PRESCRIP-TEC has shown is that self-sampling has high acceptability when it is done properly, even in the rural areas, and is guided by village health workers. The use of artificial intelligence for cancer screening, as we saw with the Saki app that was developed by the Manipal University in India, and how the AI has really a potential to play an important role in cervical cancer screening and facilitate task shifting. Besides this, when we talk about cost effectiveness, the value and affordability, the health and economic effects of when we are introducing such interventions, we did see that the testing is sort of cost effective, but for it to be affordable, we need cost reduction in the actual cost or the procedure, at least by 70 to 85%. And finally, when we look at projects like PRESCRIP-TEC and the support that is being offered by organizations such as the GSCD through implementation research, which is not only collaborative, but is multidisciplinary, has a great potential because it allows to engage stakeholders in a manner that is useful once the project gets over for scale up and sustainability, so that it can benefit the target populations in the long run. So this is what we have heard so far in terms of what PRESCRIP-TEC is, how it is beneficial, and what is the value that is the project being added. I will now hand it over to my co-chair, Dr. Helen, so that we can discuss some of the questions that have come to us. Over to you, Dr. Helen.
Thank you very much. We have 4 minutes for the questions. So I would like to ask the question short. First questions is to Dr. De Vouw and Dr. Beltman. The question is, do you know the HPV vaccination status of women enrolled in the trial or in the research?
Should I answer?
Yes, please. Yeah, yes, please.
Nobody was vaccinated in the project, and because the target groups, everybody was actually too old, so to say, to have been vaccinated at the time of screening. So nobody was vaccinated in our research population.
Okay, thank you. Then I have a second question for you. What are the plans for the follow-up of HPV positive via negative women, given the fact that there may be some risk in developing disease?
So thank you. The follow-up usually is a conform WHO protocol is after 1 year. However, there are some differences between countries. In Uganda, I already mentioned, every HPV positive woman is being treated. In Bangladesh, we have arranged extra funding for HPV testing after 1 year. And in India, VIA screening will be done after 1 year.
Thank you very much. Yeah. Thank you, Jochem. That's a very straight answer. The next question is for Dr. Kirtana Prasad. And the question is, what is considered the disease truth in developing artificial intelligence?
Pardon me, could you please come again?
Yeah, what is considered the disease truth in developing artificial intelligence? Is that the expert screening, or do you have histology, or what is your disease truth?
That is a challenging aspect. That was a very good question. The ground truth for our study we have considered as the reference, we have considered as the expert panel. However, that is also not the 100% desirable kind of ground truth, but that is where you can see that there could be slight I would say, see, the experts were all, experts' decisions were all considered, put together, and the average decision was taken as the ground truth. Now, what happens is when an expert's reading is compared with the experts' group's results as the ground truth, there is more favorable accuracy value you get for experts, experts' accuracy. So that is a big point I think we should look at. But however, in India, we cannot go for a ground truth with a biopsy. That is a limitation for the study. So for the current study, we have that is what I mentioned about the dry run. In the dry run, we established that we will be going ahead with the ground truth as the consensus of the expert panel, and that is what we have followed. Yes, so in this study, we have considered as the ground truth as the expert panel consensus.
Okay, thank you very much for your answer. I give the floor back to Dr. Ishu to start the second half of our meeting. Please, Dr. Ishu.
Thank you, Dr. Helen. So now we move on to the second part of our meeting, which will be panel discussions. We will have a set of 2 panel discussions. The first panel discussion, we will have the country representatives from the 4 PRESCRIP-TEC countries, where they will reflect on the national context and the lessons that they have learned, which might be applicable to different contexts and situations following the community sensitization or HPV self-sampling, and artificial intelligence as a promising technology, as well as the cost effectiveness. So we have 4 esteemed panelists among us, and I would like to introduce them all with you. So we have Dr. Gerald Mutungi from Uganda. He's the Assistant Commissioner for NCD's Prevention and Control Department in the Ministry of Health, Uganda, and coordinates all activities aimed at preventing and controlling NCDs within the country. We have Professor Ashraful Nisa from Bangladesh. As the chairman of the Department of Gynecological Oncology at the University of Dhaka, she is the focal point for the cervical and breast cancer screening program of the government of Bangladesh. From Slovakia, we have Dr. Kaljova as a senior officer at the Ministry of Health of the Slovak Republic and a member of the EU for Health Screening Group and Public Health Expert Group within the European Commission, as well as Dr. Lucia Kosova as the gynecologist at the Department of Gynecological Oncology at the National Cancer Institute in Bratislava. And finally, from India, Dr. Sarita Shamsundar, who's the board member for the International Federation of Colposcopy and Cervical Pathology and is a consultant and professor at the Vardhaman Mahavir Medical College and Saptashang Hospital in New Delhi, India. We will have a good discussion with all 4 panelists that will be led by my co-chair, Dr. Helen. Dr. Helen, over to you. You're muted.
Thank you very much. I would like to start a question to Dr. Mutugungui. Uganda has committed in the elimination of cervical cancer. Can you tell us what the status of introduction of a national cervical cancer screenings program is in Uganda? And is it feasible to implement high-risk HPV testing as primary screening test in Uganda? And what is needed, in your opinion, to achieve this? Dr. Mutungi from Uganda. Are you there? That's the question then. Is Dr. Mutungi available?
Oscar, can you let us know if he is connected?
I don't see
Then I
him connected, so maybe he
Okay.
has some technical problem.
Correct.
So if you can
Yeah.
skip to the next.
Okay, then I skip to the questions for Professor Asha Funetsa from Bangladesh. Dear Professor, you have been involved in cervical cancer research and screening for many years, and you have studied community involvement in cervical cancer screening. In PRESCRIP-TEC, we found the importance of involving family decision makers, like husbands and mother-in-laws, in the screening and motivate them to allow the women to participate. What is your experience with involvement of families? Is it important to increase uptake of screening in your experience? And how can we best increase uptake of screening? Professor, please go ahead with your answers.
Thank you. Good evening from Bangladesh to everyone, and my heartfelt acknowledgement to the organizers and PRESCRIP-TEC. And actually, in our experience, involvement of the family members in the decision making is very, very important, and particularly the husband and the mother-in-law. If they are motivated, if they understand that screening is needed, then there is definitely better uptake, you know. So that's why they need counseling. They need to be convinced in the that screening is needed even without any symptom. So see, in Bangladesh, if you say about 50 to 80% women, they know that there is some process, some procedure to prevent cervical cancer. There is some test available, but still they don't go because there is lack of family motivation. So we have to motivate them, and we have to increase the community awareness and through community education and through community campaigning. And we should take some programs at the community level by the community health worker, and you know, the friendship they have good health worker at the community level. Also, government has lots of health worker at the community level named community healthcare provider, health assistant, family welfare assistant. So both government and NGO should work together to mobilize the community and to use the culturally sensitive message, you know, that can motivate them, to use the flip chart pictorials, and you know, we have to motivate the family member. Then eventually the women can participate more and more in the screening program, and we can do improved coverage for this. Thank you.
Thank you very much for your answer. Well appreciated. I have a question to Dr. Kaloyao and Dr. Kosava from Slovakia. Please, doctors, you have much experience with making prevention and screening accessible to vulnerable groups. In the PRESCRIP-TEC project, it was shown that self-collected tests were highly accepted for women in the Roman community, and that the uptake was much higher than the pap smear, which is now the primary screening test in your country. Do you think HPV testing is a way forward for Slovakia, and how can it be organized? Thank you.
Thank you very much. Good morning to everybody. First of all, I would like to congratulate the PRESCRIP-TEC team, project team, for work has been done and for the results we can use for the future. For sure, the elimination of cervical cancer is a challenge also for our country, for Slovakia. Still, when we are talking about the numbers using the screening, we have still low numbers despite our conditions. So to answer your question, to the future, when we are talking about hard-to-reach communities or Roma communities with barriers to access healthcare, there is a room for a future discussion with experts how to design tailored approach when we are talking about self-testing. Of course, this was before not in discussions in Slovakia, but due your project and the results, we can have a discussion with experts how we will deal with Roma communities. The important role I see of our health promotion assistant working in the fields with Roma communities. Ministry of Health has an organization, Healthy Regions, with assistants, and the Ministry of Health is a partner in a national project. And I hope that there is a big window of opportunity how we will prepare, discuss tailored approach for Roma communities in Slovakia. Over to Dr. Kakocová. Thank you.
Thank you.
I'm able to participate now. Please repeat the question. Thank you.
That was Dr. Mutungi, or who was that asking? I cannot see.
Dr. Mutungi, but I think Dr. Kosova is trying to answer the question.
Okay, so first let us, Dr. Kochova, can you answer the question, please?
Oh, can you hear me? Okay.
Yeah, we can hear you. Yeah.
Okay, fine. I would like to explain how it's going in Slovakia.
We don't hear you anymore.
I think we lost her connection, Helen.
Yeah, okay.
So maybe we move to Dr. Mutungi and we can get back when she joins back.
Yeah, thank you very much. Dr. Mutungi, Uganda has committed to the elimination of cervical cancer. Can you tell us the status of introduction of the National Cervical Cancer Screenings Program in Uganda? And if it's feasible to implement high-risk HPV testing as primary screening test in Uganda? What is needed, in your opinion, to achieve this? Dr. Mutungi, please take the floor.
Thank you very much, and thank you for inviting me here. In Uganda, cervical cancer is a public health issue, and we have committed ourselves to eliminating it as per WHO guidance. And the challenges we have, especially for the screening, are the barriers. Women cannot access the screening centers, either because of the distance, but because also of our cultural values. Women don't like to be exposed. So when they go to the health facilities and they are told to screen, when they are going to be exposed by young nurses and young doctors, they feel uncomfortable, and in quite many times they decline. So this PRESCRIP-TEC study, which we're using self-collected sample technique, we managed to get high uptake, but also they showed us that once you visit them, once you train the community health workers, in our case, they are called VHTs. Once they are trained and they visit the families, they sensitize the mothers and the husbands and the mother-in-laws, then the women were more than willing to accept the screening. So when we did our study recently, the screening rate was only 23%. But in the PRESCRIP-TEC community where they did the study, they managed to get up to 90% of the eligible mothers to screen. So it is possible. They showed us that it is possible for these mothers to accept the screening. And they also helped us or showed us that these barriers of distance, the barriers of acceptability of the screening method can be overcome if they are found at home and they are given a self-sample collected technique. And they also talk to the decision makers, especially the husbands, the mother-in-laws, that it is possible. So we want to scale up if given resources or if we get resources. If these women are found at home with community trusted workers within the community, it is possible. And we are studying this to see how scalable it is. I hope it will be. But otherwise, we shouldn't see mothers dying of cancer of the cervix when we know the cause of the cancer of the cervix and the tools are available to prevent it. So I want again to congratulate PRESCRIP-TEC study that has shown that actually we can reach these mothers, we can overcome these barriers and reach the mothers and screen them. We still have a challenge of treatment because not all those who accepted to be screened accepted to be treated, because the treatment again brings back the exposure, the spectrum, and that uncomfortability where the women were very uncomfortable being exposed. But I think with sensitization of the community, that can as well be overcome. So I thank you very much for accepting me and inviting me to share our experience here in Uganda. Thank you, and over to you.
Thank you very much. Can you give me a short outline how cervical cancer screening program is now in Uganda? Is it already run, or is there just some projects, or is there already a national cervical cancer screening program?
Come again?
Is there already a national cervical screening program in Uganda, or are there just projects who are doing the screening?
Yes, we do have some projects doing already screening. We have already integrated cervical cancer screening in all our HIV clinics, and the PEPFAR CDC have supported us to do that screening. So, and we are again using the self-collecting sample technique. And we use the gene expert machines, which were previously given to us for TB program, but now we have added cervical cancer screening. So at least for HIV infected women, they are catered for, because in all our HIV clinics, we have integrated cervical cancer screening. We are talking with our partners to accept the HIV negative also to benefit from the same programs, because they say their funding is for HIV positive, and we find it unfair for those who are not infected with HIV. And our supplies from the national government are not adequate. So quite often the HIV negative people are turned back because the supplies are not there. Yet the HIV positive people, the supplies are there because of our partners. So yes, we have a national program ongoing, but mainly for HIV positive people.
Okay, thank you very much. It would be very good if all women would allow to get HPV screening in Uganda, and I estimate your efforts for this. Thank you very much. Is our Slovakian team there already? Dr. Kalojova?
Yes, we are here, but Dr. Kocova, she is in attendance part, so if you can remove her to the panelist. I'm not sure if she can speak as attendee.
Okay. Oscar, can you do this? Then in the meanwhile, if Oscar will connect Dr. Kosova to the panelist, then I will ask Dr. Shamsundar if you're there from India.
Yes, I'm here. Good afternoon.
You're there, okay.
Yeah.
You have many years of experience in cervical cancer screening in India. And India is an immense country with the biggest population in the world. And rolling out the screening countrywide is a big challenge. Your colleagues at MAHE are working on artificial intelligence decision support system, which eventually should lead to task shifting nurses should be able to do VIA, also with less training. Do you see this technical innovation as a way forward in expanding cervical cancer screening in India? And if yes, under what conditions?
Yeah, thank you so much, and good afternoon, everyone. Thank you for this invitation. The government of India screening in India, there's a Government of India screening program, and it's integrated with the common cancer. So it's called the National Program for Prevention and Control of. And the guidelines were established, were made in 2016, and since 2017, it's been going on in a few states. And here there is the screening for the 3 common cancers: oral, breast, and cervical cancer, along with screening for hypertension and diabetes. So the screening for cervical screening is done by VIA, and this is done by the nurses. Now, I think
we lost connection.
so the screening is done by the nurses, and those who are screen positive are then
Dr. Sarita, we are not able to hear you properly.
No,
Helen,
we
I
lost
think we
connection,
have
I think.
some connectivity
yeah.
issue.
So I think sorry, I'm getting disconnected. So the nurses can, we will be able to make a diagnosis at that time with the AI, and so the treatment also can be done significantly. However, with the artificial intelligence needs a lot of images, so it needs thousands of images to make the artificial intelligence program to be able to give the diagnosis better. And the other thing is the nurses, as discussed previously, the nurses will need to be trained to get good pictures. Otherwise, the quality of images would not be, if the quality of pictures was not good, then AI would not be able to give a good diagnosis. I think it can fit very well into the existing screening program. However, the device, the AI needs to be developed, and the training, nurses need to be trained. Thank you so much.
Thank you so much. It was for me very hard to hear your answer, but I heard that you were saying the big challenge is the quality of the cameras. Is it true?
Yes. Yes.
Yeah.
So the quality, not the quality of the cameras, the quality of the images. I mean, the nurses will need to be trained to get good quality images. And the artificial intelligence needs thousands of images from normal and as well as CI and cancer to be able to train the algorithm.
Yeah. It will be a big challenge, but there's something to do the coming years, I think, for you to get this run. Thank you very much. I would like to go back to Slovakia if Dr. Kolonjova and Dr. Kosova are there for the final answering of the question. Yeah, yes, please. Yeah. Okay, please go ahead.
Me? Okay. So sorry for technical issues. So I'd like to explain cervical cancer screening in Slovakia briefly. In Slovakia, we have combination of opportunistic and population-based screening, but opportunistic is performed significantly more frequently than population-based, which was launched in 2021. And cervical cancer screening is performed by gynecologists and is carried out during the so-called preventive gynecological checkups. And every woman is legally entitled to a preventive gynecological checkup once per year. And this cervical cancer screening is performed during this procedure. And we have also a network of district gynecologists who have capitated patients, and only patient with contract with this gynecologist, only patient which is capitated can have screening for free. So this can be maybe barrier for some people. And our primary test is pap test cytology, but we have very high quality laboratory. So but we plan to introduce also HPV testing at the age of 35 and 45 years. So I can imagine that we can increase uptake with self-testing, self-HPV testing. But maybe there can be barrier to perform further assessment because we have this network of private gynecologists and capitation. So maybe some women can have problem with access to these gynecologists without contract with gynecologists and to have further assessment of HPV positive self-test. So this is.
Thank you very much. It's a very clear answer. I would like to thank all the panelists for their answer in this round. There are some more questions, but time management is very important to be able to stop at 12 o'clock. And I would like to ask the panelists to have a look at the question and answer and in the chat, and if possible, answer the questions that are there for them and answer them digitally. And then I would give the word to Dr. Ushu for the second round of panelists. Please go ahead.
Thank you, Dr. Helen. And as Dr. Helen mentioned, that was the first round of our panel discussion where we have some interesting insights already emerging. We now move on to our second panel discussion where we move from the national to the international context. And we have a set of chief experts who will reflect on the goal of reducing cervical cancer globally by 50% in 2040, sort of to understand the status, where we are now, and what is in the pipeline. They will also help us reflect on how can we make cervical cancer screening more affordable for low and middle income countries, and what are the latest development and options that are available to us. So I will try and introduce our panel first and then lead to questions where we want to have this discussion amongst our panelists. So we are joined by Dr. Paulo Soriano. He is the scientific officer from the Cancer Mission for the European Commission. We are joined by Dr. Partha Basu from IARC. He is the head of Early Detection, Prevention and Infection Branch. Ms. Margaret B. from GACD, who is the Senior Impact and Policy Manager. Dr. Stecklenburg from PRESCRIP-TEC as the chairman of the Global Network Dutch Society of Obstetrics and Gynecology. And finally, Dr. Almonte from the World Health Organization, who's an implementation scientist at the Early Detection, Prevention and Infections Cervical Cancer Elimination Initiative. So welcome to all panelists. I would encourage all panelists to please be on video and so that we can have a lively discussion. So I will start with the first question to Dr. Soriano, who's involved in the European Cancer Mission and the Cancer Beating Program. As Europe sort of aims at innovative approaches in prevention and screening, and we see that for cervical cancer, could you let us know if we are on track in terms of when you look at from the European perspective, in terms of research into innovation of cervical cancer screening?
Good morning. Well, thank you for the question. I hope you can hear me. I was just disconnected 3 seconds ago, but I mean, eventually, I mean, I got connected back, so that's good. So first of all, thank you for the invitation and the opportunity to contribute to this interesting discussion. Actually, I joined the event from the start. I've listened to very interesting presentation, learned a lot, so that's already very positive for me. Congratulations also to the PRESCRIP team for the excellent work. Now, I will try to give you a little bit the perspective from the Cancer Mission. If I'm too long, don't hesitate to cut me. I mean, the question is broad and there is a lot I could say. So just cut me out if I'm too long. Now, I think I can safely say that cancer has never been so high on the EU health and research agenda as under the current Commission. You are possibly aware that 2 major initiatives were launched back in 2021 on cancer. So the Europe's Beating Cancer Plan on the one hand, so it's a big policy framework, and on the other hand, you know, one of the flagship under the Horizon Europe, so the Cancer Mission, which were launched really with the purpose to support member states in their endeavor to boost cancer prevention and control. Now, the two initiatives were co-developed from start. They share exactly the same objective. They actually benefit from a joint governance at many different levels, and they benefit from really substantial funding. Importantly, cervical cancer is one of the priority under the Beating Cancer Plan and consequently also under the cancer mission. So eliminating cervical cancers and other forms of cancer caused by HPV is in fact, one of the flagship is called Flagship Action 3. And this has translated really into a number of investment, both at policy and research level. So we heard earlier, for example, the importance of communication, awareness raising. So when it comes to prevention, indeed, I mean, a lot of effort has gone into really implementing or supporting the implementation of wide prevention campaign. For example, under the cancer mission, we will start now in 2024 a new we're piloting an activity. I mean, it's an innovative bus road show that will focus really on prevention and access to screening. It will be piloted in 3 countries, so that's Lithuania, Romania, and Poland. It will really focus on targeting hard to reach individuals. Also for vaccination, the goal at EU level has been set, so that's supporting member states to extend routine vaccination to against HPV to at least 90% of girls, and also increasing substantially the percentage of boys vaccinated. So this is aligned to the WHO goals. Now, in support of this, the Commission is proposing a new Council recommendation on vaccine preventable cancers, which I mean, it's HPV, but also hepatitis B, and I mean, it should be presented or published tomorrow, and then Council conclusions will follow. Also, you're all aware of the Council recommendation on screening, which was adopted in December 2022. I think this recommendation is possibly the best example about the joint work of the Cancer Mission and the Beating Cancer Plan is able to deliver concrete results, concrete impact. This recommendation is replacing the previous one that was nearly 20 years old, really following a push from the scientific community, really following the latest scientific development. The latest scientific development. Now, for cervical cancer in particular, the screening, as the goal is to ensure that testing is offered to 90% of the eligible population, so women between 30 and 65 every 5 years or more, depending also on the HPV vaccination status. Now, considerable funding is going into supporting the implementation of these recommendations. From the research perspective, I mean, if we look really at what has been funded only in the last few years, I would say 6-7 years between the last part of Horizon 2020 and now under Horizon Europe, I think all in all around 50 million euros have gone really into cancer, into research on cervical cancer, and this is very, very, very broad. I mean, I would say cervical cancer throughout the continuum. So it's behavioral science, tackling inequality in access and quality of vaccines, screening, but also implementation of vaccination and screening campaign, improved screening methods, including self-sampling, but also treatment follow-up. I mean, this includes also, for example, all the support that has gone through the Global Alliance for Chronic Disease we heard earlier from Dr. Roberts. Now, maybe a word on artificial intelligence. We heard earlier. I mean, all the work that is going very fascinating. I mean, what was presented with from the project. Now, I think we all agree that the impact that artificial intelligence and the transformative role that artificial intelligence can have, including in the health sector, is very high. And the EU has embraced this potential. There is really substantial funding that is going into supporting excellence in artificial intelligence. Beyond that, we are also looking at let's say we referred also earlier, the importance that artificial intelligence is used in the most ethical way. And in fact, the Commission has proposed very, I mean, there was in 2021 a big legal framework, to support really the application of artificial intelligence. The framework is based really on risk assessment. And it has really very, very recently agreed, the text of this legal framework, it has been agreed by the legislators, so the council and the parliament. So it will become law in the next few months. And it's the first of its kind. It's first legal framework tackling artificial intelligence, and we hope, this will inspire also other regions to do the same. Now, just to conclude, sorry, I'm taking a lot of time, but I think a lot is really ongoing. I just wanted, I tried to show you at least that there is a lot of funding, a lot of opportunities, a lot of actions, a lot of initiatives that have been implemented through the cancer mission, through the cancer plan, but also, before under the other research framework programs. A lot of results, very interesting results are coming. Some of the projects have just started and will deliver in the future. The challenge will be really then to make sure that all these results, all this very good material is indeed translated into concrete solutions, is translated into really, policy changes, policy activities, and therefore the importance of really maintaining alive the dialogue, bringing all the stakeholders together, being them policymakers, but also scientists, healthcare professionals, patients, and citizens in general, to really exchange, peer learn, and in that sense, identify gaps and possibly co-create solution. Thank you.
Thank you, Dr. Soriano. I think that was a brilliant context in terms of what is happening and how do you envision the research. As you said, I think it's very important that the research that we do is sort of translatable, it is actionable and policy oriented, so that we can see the implementation and thus the benefit to the population that we want to offer. We now move on to Dr. Basu. So Dr. Basu, as the leading technical agency in cancer research, IARC does a lot of work around cervical cancer. What we heard in the PRESCRIP-TEC sort of descriptions, and one of the main issues was to get a good point of care test for HPV. And there were some challenges that we were seeing, which were in terms of the labs or the logistics or how to train the staff. And we need like a cheaper test, because we heard about the affordability piece in the cost effectiveness presentation. So what is your perspective on achieving this in future, and how can we make HPV testing feasible in low and middle income countries?
Thank you. Thank you so much, Ishu, for the question and also for having me in this panel. When we are considering a point of care test, there are two issues that we need to focus on. One is the technology, another is the implementation model. So from the technology point of view, say for example, at the present moment, the best point of care tests that are available till date are the cartridge-based tests that require almost no pre-processing of the sample, and the readouts can be obtained even for a single sample. However, problem with these tests is that the tests are quite costly. The platforms themselves are also expensive. So there can be two solutions to this. Number one, developing indigenous tests, and number two, introducing innovative technologies. Now, IARC is collaborating with the All India Institute of Medical Sciences in India to validate 3 homegrown tests. These are essentially repurposed COVID test platforms, and they are cartridge-based. They'll include, some of them include less than 10 HPV genotypes that may have some implication with the cost. And these indigenously manufactured tests can bring, especially in an LMIC like India, can bring down the cost. Similar initiatives are also ongoing in China, Brazil. So we need to see how we can support this kind of tests that are either repurposed COVID platforms or existing tests that can be validated, and then they can be brought into the area of cancer screening. Second thing, when it comes to new innovations, there are a lot of activities going on in that area as well. So for example, Boston University is working on a test in which the sample needs to be mixed with a reagent in a test tube, and the mix is smeared on a paper strip to obtain results in 30 minutes. There are PCR machines that are being developed that weigh less than 1 kilo, and they are preloaded with the reaction mix, with the reaction mix. And The machine with preloaded reagents will cost less than 300 USD, and we will be able to perform 2,000 to 3,000 tests before it can be discarded. So again, these are technologies that are coming up, but then they need to be appropriately validated before they can be used in a screening area. So, but then there is a lot of work ongoing on that side. However, it is also important to focus on the correct implementation model for LMICs, as, say, for example, all the primary cares will not be able to have a machine. It's impractical to think that the health systems will be able to afford to place a machine at each primary clinic, or each primary clinic will have adequate number of women to be screened to justify setting up a machine there. So we need to think of a hub and spoke model, in which clinics with high footfalls will have hubs, and the rest of the clinics can be linked with it as spokes. The machine can be installed at the hub, and this will be useful till we have a test like a pregnancy test that is a really point of care. So as the technologies move, the technologies evolve, we also have to think of the right implementation model, and it may not be the same implementation model across the different settings. We have to be a little innovative in that area as well. Another important thing for bringing down the price of tests, especially for highly populous countries like India, Bangladesh, Uganda, is to think about the power of pooled procurement when the programs are negotiating with the companies. The power of pooled procurement or pooled purchase is that the companies look at the scale, and they are ready to afford, they provide very special prices. We have seen that power of procurement, pool power of procurement in vaccine procurement in PAHO countries. So maybe that is something we need to think about when it comes to purchasing consumables for HPV detection tests in countries like India, Bangladesh, or Uganda. I'll stop here now. Thank you.
Thank you, Dr. Basu. I think I want to follow up on a couple of points that you made, which were very relevant. I think the first thing that you mentioned was the focus that we need to do on health system assessment, because it will not be possible like to put machines everywhere, but we have to understand what is the capacity, because when we talk about implementation, we also have to think about sustainability of what we are trying to do and for health systems to adapt. So I'd like to know a little bit of your thoughts on the importance of health system assessment. And the second thing that I wanted to ask, which you brought up, was the importance of cultural context and the setting where we are doing it. So the implementation is very much related to where you are doing it in terms of setting. So a little bit of more thoughts and reflections on those two aspects, Dr. Basu.
Thank you, Ishu. I think that's the crux of the whole concept of implementation science, implementation research. We need to find out context-appropriate solutions. At IARC, we are also doing some studies where we are looking at how to improve participation to screening for the vulnerable population in Europe, also in India. So where we have there have been several studies that have looked into the barriers at the level of the women, at the level of the providers, but then the systems level barriers are more important to study, and that is to my understanding has been less looked at. So what we are doing is we have come up with a protocol for facility assessment or understanding the capacity of the health systems to incorporate, say, for a new intervention like HPV detection test. And this requires, of course, to go through the policies that are there, what existing work that is being done that is there in the literature. But more importantly, it is important, we have to visit the facilities to understand really how the facilities work. What is that average capacity, average number of women seen in a facility? In a facility that sees 50 women a day, there is an advantage, because you set up a machine that can provide 50 tests a day, your consumables will be utilized. But the flip side of that is the nurses there will be very busy. So you need to think about how you engage, have adequate manpower in that kind of busy setting. There may be small clinics, or there may be only a few women coming there. Then you have to think whether is it really necessary to put a machine in this kind of situation. So that is one thing. You need to think about the logistics of transport of the specimen. Because once the sample is collected, it has to be shifted. Even within a same facility, we have seen there are challenges in sending the sample from the clinic to the lab because there is nobody designated to do that. So all these issues can be looked at when we do this kind of facility assessment, which is a very structured way of doing it. And after the facility assessment, we go for an in-depth interview with the facility managers, other program persons. So this capacity assessment is something that has come out again from one of our 2020 and GSCD supported CBIG screen project, we call it. That includes, as I said, understanding what is going on from the literature, doing facility assessment, and doing in-depth interviews to understand what is really feasible in that particular context. And this study is going on in Portugal, in Estonia, in Romania, in Europe, and of course in India, in multiple states. Thank you.
Perfect. Thank you, Dr. Basu. Those were very clear reflections on the importance of health systems assessment and the cultural context. We will now move on to Ms. Margaret P. So Margaret, as an expert in health systems research, when we look at the PRESCRIP-TEC project, it used an approach and proved that the WHO screening protocol is feasible. But for the rollout, in terms of its scale up and the rollout, we need strong health systems where you can integrate screening in primary healthcare. What would you say in terms of the support that is being offered by GACD for health systems research, and what we must think in terms of scale up when we are looking at such screening approaches, both nationally and globally?
Thank you, Ishu. Yes, at GACD, we do support health systems research. And as Morven mentioned in an earlier presentation, we particularly focus on implementation research, of which the PRESCRIP-TEC project is one. And we've talked quite a lot about implementation research and looking at context in which we're implementing. Within GACD, many of our projects support health systems, strengthening health systems and adapting health systems to be able to implement the interventions. So, for example, we have a number of projects working on task shifting, working with community health workers, working with communities and improving access to health services. So this is absolutely something that is a priority for GACD. Morven gave an overview of how our funding has moved from being disease-specific to more integrated approaches and working through strengthening health systems and strengthening access to services, which is really important for us. So in relation to the second part of your question, looking at what is needed for scale up, I'm really interested that Dr. Basu just talked about doing health facility assessments. In my previous life working for NGOs, I did a lot of health facility assessments, looking at what is the capacity of the health system, what is needed in terms to be able to strengthen that and enable them to be able to implement these different interventions. So in terms of being able to implement screening within the health facilities, we need to really integrate those within the existing primary healthcare clinics and to strengthen the capacity where that is needed. We have seen that funding approaches in the past have often created silos in that they have just addressed one particular health concern. But there's definitely agreement now that we need to focus on integration and strengthening national health systems. So a key part of this is working with the health workers who are already there in those health facilities. Those health workers, we've talked in the different contexts, I've heard community health workers, village health teams mentioned, who are supporting the rollout of the screening in the communities, but also the health facility workers who are then following up and working with the patients. So we need to make sure that those health workers themselves are supported through the health system, that they are trained, that they have the skills needed to do the screening, and that they really are part of that health system and that chain to be able to refer further down. I like the idea mentioned of the hub and spoke model, and looking at what sort of health facilities they are. If they're very small clinics, then like Dr. Basu said, we're not going to necessarily do that many tests in that clinic. So being able to link them to larger clinics. We really need to engage with the women themselves, also with the husbands, mother-in-laws. We've heard a lot about the need for capacity, community engagement, for awareness raising, to know the importance to be able to make those decisions, to be able to come for screening. Obviously, the home screening has improved the accessibility, but we really need to work with communities themselves. And also equity is such a key thing. We know in many contexts that people do not have equitable access to health services, and we really need to focus on equity. This may need broader approaches to tackle the social determinants of health and other aspects beyond the health system that affect people's access to services. It's really promising hearing from the PRESCRIP-TEC team about how the self-tests have been really accessible, and that kind of approach is a really good way of increasing equity and reaching people where they're at. So that's really key. Great that the first panel was really focused on country representatives, and I was really interested to hear in the different settings how this has how the PRESCRIP-TEC findings have informed what's going on, how there seems to be quite positive feeling about this going forward. Obviously, the cost is an issue, but looking at kind of how this can be scaled up and how costs can be reduced. But in order to scale up projects nationally, we really need the buy-in from the policymakers. We need them to support what we're doing. In implementation science, we involve the policymakers right from the beginning of the project. And I know that that has been done with PRESCRIP-TEC, that the national policymakers have been engaged and involved in the design of the project and the decisions around how that is implemented. So it's absolutely key to involve the policymakers, to engage them, to look at how screening can be implemented in their country. Many countries have national strategic plans on NCD integration into health. These quite often are quite high-level plans, but they show a country's commitment to tackling NCDs and to integrating them into primary healthcare, universal health coverage, but they need to be accompanied by the policies and protocols on how to implement the screening and different interventions. I have seen the second part of your question asks about global scale up, and I'll be really interested to hear what my fellow panelists from WHO has to say, but I feel like we have strong leadership from WHO in this area, which is absolutely critical for global scale up. On a number of health issues, we've seen that countries are much more likely to prioritize an intervention if there are clear guidelines from WHO. We have WHO screening protocols. We have the cervical cancer elimination strategy. We also have the best buys, of which there are 2 on cervical cancer screening and early diagnosis. I think the best buys have been really key in terms of helping countries to be able to prioritize where they are focusing, which interventions they want to focus on, particularly when they have limited resources. So I feel like strong leadership from WHO is absolutely critical, and we're already seeing that. And I know WHO is supporting in country as well, to support the national ministries of health. Also, we've talked, when we talk about global scale up, we really need to be focusing on those lower middle income countries where the burden is highest. We're all aware of that, but it's easy to say global when the resources may be going a bit more to the high income countries, but actually how can we improve screening and early diagnosis in the low middle income countries? So yeah, in summary, just to support the scale up of screening approaches, I think the key things we need are strengthened and integrated health systems, support for health workers, involved communities, engaged policymakers, and equitable access for all. Thank you.
Thanks, Margaret. I think those were some of the very key sort of points that you summarized at the end of what is needed. I think I have a follow-up question for you, Margaret, and that is from a GSCD perspective. When we talk about implementation, and you were mentioning that there are guidelines that are there, and you have the guidelines that are coming from organizations like WHO. When we look at the translation of these guidelines in terms of implementation at the local level or at the national level, I'm trying to understand, with the support that GACD offers, are there projects that are trying to do that? Because we need to understand the challenges that are related to implementation when we're trying to translate these international guidelines or global guidelines into a national context.
Yeah, so that's a very good question. I think there are, at GACD, we cover a number of different NCDs. And when you get to this level, you're looking at specific guidelines for implementing specific interventions. The ideal is that the national, the country has their own guidelines on how to implement that intervention in their context, because we know it's so context specific. So we may have a global guideline from WHO, and that will be showing that a particular intervention is effective in settings where it has been tested, but it may not have been tested in Bangladesh, for example. And we may not have a particular guideline on how to implement that in Bangladesh. So a lot of our research projects will be taking those interventions from global evidence and implementing them and testing them, usually starting with a pilot and then eventually planning to scale up onto a larger context, but implementing them in a particular setting and looking at how that needs to be adapted. So, for example, we've heard about Dr. Mutungi was saying in Uganda that they use village health teams to visit homes. Well, that's in Uganda, and they want to have that established system of village health teams visiting women in their homes. And they can use that system that they already have in place to then implement and strengthen the screening. But that might not be appropriate in another setting. So our projects, our research teams will be looking at the context in which they're working and how they can implement that intervention. But then also working with the policymakers right from the beginning of the project to, if there is a policy that already exists, to look at how that can be rolled out and integrated into routine practice, because that's often the case, that we have a policy, but it doesn't actually get implemented. But where policies don't exist yet, to work with those ministries of health and decision makers on how to develop a policy that's specific to their context. So on our website, we have a number of case studies, and we're looking at kind of how we work in different contexts and how we've been able to change policy. We also have a top tips for engaging with policymakers, which we've included examples from projects of how teams have done that and how they've worked. So, for example, we have a project working on TB and tobacco, and it's working around reducing tobacco use among TB patients. And they have actually used members of some policymakers on their team involved in the decision-making around how to roll out that. And that intervention around counselling for patients with TB has been integrated into their national policy now for the tobacco stopping smoking kind of messages have been integrated into their TB programs nationally. So that's an example, that's one of our case studies. But it's a question of working very closely with the policymakers on their specific issue and looking at the context and what systems they already have in place and how the intervention can be integrated into that context.
Thank you, Margaret. We now move on to Dr. Scatlenburg. As the principal investigator of this project from the Netherlands, what are the lessons you think can Netherlands learn from the PRESCRIP-TEC project? And how can the cervical cancer screening in Netherlands be improved, as you saw it was achieved in the PRESCRIP-TEC project? Over to you.
Thank you so much for your introduction and your question, Madam Chair. I hope you can hear me well.
Yes.
Since we are coming close to the end of the webinar, I would like to take the opportunity to thank all the colleagues with whom we have been working together within PRESCRIP-TEC, and also all the people contributing and attending this webinar. For me personally, mainly having been working in maternal and neonatal health research, it was a great learning experience. In the past decades, I was repeatedly reminded by one of the co-chairs of this webinar, Dr. Helene van Beekhuizen, that the number of women dying from cervical cancer is as high as the numbers of maternal deaths. It was a great opportunity and achievement for the UMCG to win the EU grant for PRESCRIP-TEC and to be the leading partner in a very wide consortium. All partners worked tirelessly and we're very happy to present part of our achievements today. The analysis of our data is still ongoing and it will still take a year or two for our PhD candidates and the postdocs to prepare the final scientific manuscripts presenting our findings. Now, let me come back to your question. In the Netherlands, participation in the cervical cancer screening program has been relatively stable. For many years, attendance rates ranged roughly between 60 and 70%. The implementation of HPV-based testing took place over the first quarter of 2017, and the participation rate dropped due to some organizational mistakes to 60.3 in 2016, and even below 60, 57.4 in 2017. However, according to the fact sheet produced last year by the ICO IARC Information Center on HPV and Cancer, the estimated ever screened for HPV coverage in the Netherlands is now 97 to 98%, and around 70% was screened in the past 5 years. In the first 2 years of the new program, only 7% of screening tests were performed on self-sample. Subsequent more active promotion and increasing the ease to obtain kits increased the proportion opting for self-sampling to 16% in 2020. Another intervention to increase uptake was a greater involvement of general practitioners in the program. The effect of having an invitation sent by the GP has been shown to have a greater impact in groups that have lower attendance rates, such as young women, women with a migration background, and women with a lower socioeconomic status. Now, what can we learn in the Netherlands from the PRESCRIP-TEC experiences? In PRESCRIP-TEC, we showed that community sensitization contributes to increased uptake and must include family decision makers like husbands and mothers-in-law. We confirmed that high-risk HPV self-sample testing as primary screening is very convenient for women and helped to increase uptake in our target areas to over 90%. Importantly, and not unexpected, we found that in the follow-up process of screening of high-risk HPV positive women, we need to avoid dropout and convince women to come to the clinic in order to achieve an uptake of 90%. And we found that artificial intelligence is a promising technology for decision support to health workers who perform VIA. We suggest that the screening protocol could be cost-effective if costs for HPV tests are reduced to make it more affordable for lower and middle-income countries. When I try to translate these PRESCRIP-TEC findings and integrate them into the Dutch situation, I conclude that first, intensifying the community sensitization program will probably also help to further raise uptake in the Netherlands. Self-sample testing is convenient for many women, but health worker sample testing should also be available. Invitations for the screening program from a trusted healthcare provider rather than a government organization will help women to participate. And lastly, AI as a decision support system is a promising innovation for VIA. So why not for colposcopy? I think in the Netherlands, it can accelerate task shifting and make more cost-effective use of scarce personnel possible. But more research is needed and planned on that. Thank you.
Thank you very much. And we move on to our final panelist, Dr. Almonte. As the lead technical agency, WHO is sort of the driving force behind the cervical cancer elimination strategy. In your perspective, when do you think are the targets going to be achieved? And when we looked at the PRESCRIP-TEC project, we did find that there were issues of affordability of the strategy when we looked at low and middle income countries. So how can those countries be supported so that they can also achieve those targets?
Thank you. Are you listening me well? Because my headphones ran out of battery, so I was trying to reconnect them. Very well. Okay. Thank you very much for inviting me to speak in this panel and actually to listen to the study, which is the first time that I'm encountering it, and I found it super interesting and very comprehensive on all the screening spectrum. So at WHO, as you all know, and it has been mentioned several times in this meeting, we are leading the cervical cancer elimination initiative, and we are now 3 years from the launching of the strategy for the elimination. And as mentioned, this strategy includes 3 pillars, and we are focusing here today on the second pillar of screening and treatment. In WHO, we have different, we are working in different fronts. One of the most important ones is in norms and standards. And by that, I'm leading the Living Guidelines on Cervical Cancer Screening and Treatment, which has as an objective to rapidly, or actually we could say like properly update the evidence on new on innovative strategies or techniques or treatments, and also to update the recommendations that are already up there with regards to screening and treatment. And so this actually includes evaluating novel technology, and we have 5 priorities for the coming years that I want to mention. 4 of them are related to HPV tests, so HPV extended genotyping, HPV point of care tests, HPV self-sampling, and all the major uses that we can have. And then the 4th one is the artificial intelligence for cervical screening and treatment, particularly for cervix visualization. So as the first part, and working on this, the first part that we've tackled, because we are collecting the evidence and monitoring the evidence, what we are doing in parallel, we are completing now, is to work on the target product profiles for HPV tests, something that has been mentioned by all the speakers, the challenges that we have to get an affordable HPV test and the available HPV tests at countries. So basically, the target product profiles are list the characteristics, both minimal and preferred, for novel tests, for new tests, or for those tests that still require validation, which is the case of many tests in the market, as you may know. So, and I would like to highlight that both in these target profiles and along all the work that we do, we are highlighting 2 points. One is the extended use of self-sampling, together with extended genotyping, partial genotyping, or any point of care test. And the other is actually the use of point of care tests as well, and where they can be used. We heard Dr. Basu saying that it depends on the context. We can have different models on how we're going to use central testing or spoke and hub testing or point of care testing. And that actually brings us to the next topic, which is implementation research, of course, also targeted by all the study and all the speakers. At WHO, we are working on a large area now on implementation research for NCDs, for health, and particularly for cancer, and within that for cervical cancer. And we are working with partners in the NCI and in the US to develop a policy brief on implementation research, first for developing cervical cancer networks, and then to work on further on all cervical cancer control and cancer prevention and control in general as part of our work. I also would like to highlight that the WHO guideline on screening and treatment that I am saying that will be updating according to the evidence that comes out on novel technology and on what we have now, it tries to address or tries to propose recommendations that are useful for low and middle income countries as well. And we would like to have you all, and all other stakeholders and collaborators that we have globally to actually try to align research according to our guidelines. And when the time comes and we consider, for instance, that artificial intelligence is very promising, and my main feeling would be for colposcopy, as mentioned just a minute before, but also as triage of HPV-positive women to support AI and to visual inspection and to improve perhaps the performance of visual inspection and all that. But we still do not have enough evidence to recommend this artificial intelligence, particularly in this use case. However, we are trying to assemble, as of course, a working group to start working on this. This is another area that WHO has taken seriously, and I mean, over the years, and mentioned by all the speakers as well, we know that artificial intelligence is one of the main topics right now, not only on research, but in general. And WHO is developing policy regarding the use of AI in health. I want to then move into the question per se. So basically, we have another mandate that we have is really to give support to countries. And as mentioned by my preceding colleague, Ms. Margaret B., WHO has the role to actually support countries to elaborate the norms and standards that are useful for countries and to support countries into the implementation of that. And with that, we are also working on guidance for implementing our screening and treatment guidelines, but also we offer technical support to countries when they actually call for it. We are aware of the challenges for introducing HPV testing in countries. Name the price of the test, the assuring that women that are HPV positive are either treated or triaged or treated straight away, and all the complexities of screening and treatment. But we are sure that there are many countries that have really are reaching the goals of HPV vaccination, and we have some successes towards the elimination altogether. We have the case of Bhutan that has over 95% of or 99% of vaccinating cohorts throughout the years. It has over 90% screening coverage and over 90% of treatment of those that turn out to be screen positive. We also have other examples in Latin America in particular. We know that El Salvador is moving rapidly towards elimination using a screen and treat. We also have Costa Rica that is now moving towards elimination, not using a screen and treat, but a more elaborated screen triage and treat process. So there is success. And it is true that for 2030, we will not reach the global targets of 70, 90, 70, because there are so many concerns and we were hit by the pandemic, which gave us some good lessons to use in terms of laboratories, in terms of integration of services, which is fundamental for us to move on. But we have to accept that that will be difficult. However, looking at the successes of some countries and the movement that has passed since the call to action and until now, we really believe that if it's not going to be for 2030, it will be soon after. And we are working together with many stakeholders, and I invite you also to be part of this community, not only on research and on implementation research, but also on implementation itself. We support all our stakeholders in the countries, and we're trying to move all this community of practice and all this global community to actually support the elimination. We consider that the main uptake for screening in our case will be self-sampling. We consider that that will actually give the right to women to decide on how to be screened. They need to have the right, and we need to work, as mentioned before, with women, with the public, with health workers, with policymakers, and also with all the stakeholders, all this community of supporting agencies, funding agencies, and all of those that are working in countries. And I think together we can reach there. Not in 2030, perhaps, but we will make it. Over. Thank you.
Thank you. Thank you, Dr. Almonte. And I think that was a perfect sort of call to action to all of us present here of what we need to do. I know we are left with only 2 minutes. What I would do is share that we are very grateful to have all the panelists and the presenters amongst us. We have heard some great sort of insights from our panels and from our presenters that talk about the research that we are doing to be actionable and policy oriented. We need to understand the cultural context where we are working from, the role of health system assessments, the key to study at system level barriers, the role of integration in health systems and how it is key, and including communities where we talked about not only the women, but also the decision makers as well. We also heard some of the key messages that came out from our presenters of the HPV test to be more affordable and collaboration which is needed for the public and private partners to work together. And also finally, the key thing that I think Dr. Almonte also pointed out, the role of self-sampling, where we've seen that it is accepted well by the community as shown in the PRESCRIP-TEC. I will now quickly hand it over to my co-chair, Dr. Helen, to see if she has any final reflections before we
Thank you very
close
much, Ishu. I have some final reflections. I think we're all very hopeful for the future, that we have built in the past years an extremely good network. You as PRESCRIP-TEC, but also international with all other organizations who are involved in cervical cancer screening and treatment. PRESCRIP-TEC is not finished yet. The reports need to come, but I would like to thank all the researchers, all the people involved, the organizers, the logistic people. You've done a tremendous job, and I think it's very nice to have seen these results. I suggest we show the small video now for the ones who have some time left. There's a 10-minute video with a layout of the study. If not, I would like to thank you all and wish you a good afternoon, evening, or night, wherever you are. Thank you.
Thank you, Dr. Helen. And I don't think we have that much time, but just wanted to let you all know that the recording of the webinar will be available at the final conference on the PRESCRIP-TEC website. And you can learn more about the project at the www.prescriptec.org website. Thank you, all of us, again for having with us. And thank you for all your contributions. We are very grateful. Have a wonderful rest of your day. Thank you.